Hello, friends, and welcome to episode 1249 of the Juicebox Podcast. Today, on another episode of the Grand Round series, we talk to a pediatric endocrinologist. Dr. Kasim's going to pull back the curtain and share his perspective on endocrinology. Nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan. T1dexchange.org/juicebox. You want to help? You can. Go to that link, join the registry, complete the survey, and just like that, you will have helped with type 1 diabetes research. That's T1dexchange.org/juicebox. Do it as a favor of me, please. Take you like 10 minutes. Let me pay back that favor. If you like comfortable and quality, you're going to love CozyEarth.com. Go there, buy whatever you want, save 30% off of everything you get with the offer code JUICEBOX. And don't forget the private Facebook group Juicebox Podcast Type 1 Diabetes on Facebook. It's the greatest community there is, bar none. It's a private group, so you have to answer a couple questions to get in, but after we know you're not an algorithm or an evildoer, we'll let you right in there and you can meet 51,000 other people living with diabetes. Juicebox Podcast Type 1 Diabetes. No evildoers allowed. Did you know if just one person in your family has type 1 diabetes, you're up to 15 times more likely to get it too? So screen it like you mean it. One blood test can spot type 1 diabetes early. Tap now, talk to a doctor, or visit screenfortype1.com for more info. Today's episode is sponsored by Screen for Type 1, and also US Med is sponsoring this episode of the Juicebox Podcast, and we've been getting our diabetes supplies from US Med for years. You can as well. usmed.com/juicebox or call 888-721-1514. Use the link or the number, get your free benefits check, and get started today with US Med. The podcast is also sponsored today by Omnipod 5. That's omnipod.com/juicebox. Get over your FOMO, fear of missing out on Omnipod, and get started today with the Omnipod 5 using my link. Links in the show notes, links at juiceboxpodcast.com, to screenfortype1.com, US Med, Omnipod, and all of the sponsors. When you use my links, you're supporting the production of the podcast and helping to keep it free and plentiful.
My name's Nader Kasim. I'm a person who has type 1 diabetes. I was diagnosed when I was 18, but I'm also a pediatric endocrinologist. I just like diabetes a lot. From the sense of an academic perspective, I think it sucks as a disease.
Yeah. Let's pick through it a little bit. So you're 18 when you were diagnosed, Nader?
Yeah. So I was 18. It was the first semester of college. It was when I was getting ready to learn medicine. It kind of hit me like a brick wall, presented in DKA. I was in the hospital for like a week. I had all the symptoms. I lost like 20 pounds.
Yeah.
Didn't know what was going on.
Not in your family? Nothing you were expecting?
Not really. I have a distant relative with presumably type 1. Mm-hmm. But everyone else has type 2.
Gotcha. Presumably type 1 means they don't know, but that's probably what they have.
Yeah.
Yeah. Just so old they don't talk about it that way.
Yes.
Yeah. Gotcha. I have diabetes. I can't drink soda. Something like that.
More so, several generations ago. So can't explain what was happening at the time.
How about other autoimmune issues? Anything like that in your family or for yourself?
No, actually. No thyroid, no celiac, no inflammatory bowel disease or anything like pernicious anemia or anything like that.
Nice. I'll knock on wood for you. That's very good. Keep that going for you. So you're diagnosed at 18. You're away at school or somewhere local to your family?
So I was kind of both. I was actually at school. I was living alone, but my family lived in the area. They were there. I had support, but I didn't see them often enough to really get their input on how to deal with things.
Okay. How long ago was this? How old are you now, I guess, is my question.
Yeah, so I'm 37.
19 years.
Yeah, you can do the math.
Yeah, look at me. It's pretty impressive. Yeah, you saw me, Nader. I was like, 38 would have been 20. I'll just take one off of it. And there we go. That's exactly how my brain did it just now.
So I do the same.
Yeah, of course. So, okay. So it's an interesting time, right? because you're diagnosed, people know you're a kid still, but you're away at college. So there's not a lot of, there's not a lot they can do. If you want to keep going to college, they're not going to know. You also start learning about diabetes, presumably, or hopefully, while the rest of your family is not brought up to speed. So was that your finding? Like there was no one to help you?
I don't know if I would say it that way. There are people there. It's just, even though symptoms happen relatively rapidly, because it's progressive, it takes a while for someone to say something. Mm-hmm. So, even it took 20 pounds of weight loss, falling asleep in the middle of class for someone to say something. And it really took someone who hadn't seen me for a bit to say, you don't look well.
Mm-hmm. And it's hard because not everybody, I just had a personal experience. I've lost 40 pounds using GLP medications in the last year.
Nice.
And I'm looking for 20 more, by the way. And then I'm done. I was out in public. I saw a person I hadn't seen in years, and we're talking back and forth forever. And at the end, I said something about that. And the relief that came over them was really something, because she said, "Oh, I didn't want to say anything. I thought maybe you had cancer." Like it was that I looked that different to somebody, but still she wouldn't mention it. So like it's interesting that it takes a person who hasn't seen you in a while to notice enough of a change, but they also have to make the leap to say to you, "Nader, are you okay?" It's really something. From your perspective, Did you notice the weight loss?
Yeah. So, you do notice it. It's just, you find other explanations for it. And we've all heard this, right? Mm-hmm. Like it's, I thought I was getting sick with something else, or had a stomach virus, or, so you play mental games with yourself. And because although it's rapid, it's progressive. Mm-hmm. It's really hard to draw a line in the sand to be like, all right, nothing's right. I need to go seek care, especially as an adult.
Then how was your care? What did it look like for you? 20 years ago that's faster acting insulin time, right? You were doing, I would imagine you started with MDI with something like Levemir or Lantus.
So I was in DKA. So I was basically taken to the emergency room mm-hmm. by a family friend. And, I was started on insulin drip, and I was in the ICU for several days. And then when my DKA, or my diabetic ketoacidosis, resolved, they switched me to injections. At that time, it was Lantus by vial, mm-hmm. if I remember correctly. And rapid-acting insulin was also by vial. Pens came out or became more prominent shortly thereafter, so I switched relatively soon.
I see. And were you taught to count carbs at that point? Getting older means a world of change, but some things still stay the same, like being at risk for type 1 diabetes. Because type 1 can happen at any age, so screen it like you mean it. If just one person in your family has type 1, you're up to 15 times more likely to get it too. And 50% of type 1 diagnoses happen after the age of 18, so screen it like you mean it. Type 1 diabetes starts long before you need insulin, and one blood test could help you spot it early and lower the risk of serious complications like diabetic ketoacidosis, known as DKA. So don't get caught by surprise. Screen it like you mean it. Because getting answers now can help you get prepared. The more you know, the more you can do. So don't wait. Talk to a doctor about how to get screened. Tap now or visit screenfortype1.com to learn more. Again, that's screenfortype1.com, and screen it like you mean it. This episode of the Juicebox Podcast is sponsored by Omnipod 5, and I'm here to help you get rid of your FOMO, fear of missing out on Omnipod. I see people all the time in my private Facebook group talking about their love for Omnipod 5. Have you seen those posts and thought, "Ooh, I wish I could have that experience with an insulin pump too"? If you answered yes to that question, you might be experiencing FOMO, fear of missing out on Omnipod. Now, if you have FOMO, it could be impacting you in all kinds of ways. Maybe you look at a body of water like a pool or a lake and think, "Oh, I can't go in there. I don't want to have to undo my pump and take off the tubing and all that stuff. I wish I could just jump in." Well, you could with an Omnipod 5. You might also just be scared. You look at a doorknob and you think, oh, it's coming for me. Gonna take my tubing off. You won't have that thought with Omnipod 5. I want to get rid of your fear of missing out on Omnipod by getting rid of these concerns. Fantasizing about jumping into a swimming pool without disconnecting or just wishing you could wear outfits without pockets, you're dreaming about Omnipod. The good news is you don't have to suffer from FOMO any longer. You can see all about Omnipod 5. See what you're missing at omnipod.com/juicebox.
So no, I was a carb exchange guy.
Mm-hmm.
The hospital I was diagnosed at was effectively a community hospital. So from a diabetes education perspective, I got everything that I needed, but I wasn't really given the whole picture. I was basically told, this is how you dose insulin. You're supposed to, one carb exchange equals this. If you eat multiple carb exchanges, you take this amount of insulin. It's given a sliding scale. I remember on the discharge summary, the sliding scale wasn't complete. It was all handwritten and it wasn't completed. So I remember I had a high blood sugar and I was like, oh snap, I don't know what to do next. Yeah.
How long did you manage that way?
So the way it worked then was they would actually refer you to your primary care provider, and then your primary care provider would refer you to an endocrinologist. So I'd say it took me about half a year to connect in between the two. So I don't know if I really got any formal education or, kind of like a medical home for a bit.
Okay.
So really unfortunate.
Yeah. So the healthcare provider just turns into the person who gives you like, here's needles and you need a prescription for this and that kind of stuff.
Yeah. Yeah. And I think from a medical perspective, like I was given enough to kind of deal with the circumstance at the time, but you don't get any of the nuanced stuff that, you kind of wish that someone told you later. Like, this is how insurance works, like half your supplies might not come through a pharmacy. This thing costs $1 bazillion, but yeah.
Pre-bolus.
So.
Yeah. What? No, I'm always high after I eat. Does it come back down? It does. Then it's fine. Yeah. That's the extent. So do you know what your outcomes were like say through your undergrad, for example?
Yeah. So I was pretty well controlled. So I honeymooned. So that helped a lot. And I kind of honeymooned for a bit, probably say close to 2 years.
Mm-hmm.
I think it didn't take me long to figure out the impact of nutrition and activity and whatnot on blood sugar control. It did take me a while to understand what the big picture would be as far as, what the point of treating diabetes is. I'd say I lived a big portion of my life genuinely having the goal of not being back in the hospital in DKA, when in all reality, that really isn't your primary driver.
Right.
It's not to have a heart attack or stroke or so. But I think for the most part, I did well. I did a lot of self-learning. I wish that there were podcasts at the time that, that would effectively, supplement whatever care I did not get or supplement the care that I actually got. There were books. I was in college, so I was able to read medical literature. I fared.
Yeah. Okay. It's interesting that you would say not interesting. Like, oh, I can't believe it. I hear people say it all the time, but that you didn't even have a goal in mind is kind of fascinating, right? I mean, 20 years later, doesn't that throw you off as a pediatric endo that an 18-year-old kid would be out in the world at college and not know why he was doing what he was doing?
Yeah. And honestly, I still see this all the time. In between transfers of care that we get and people who've had diabetes for years, I ask that question. I'm like, you're going to come see us every 3 months. What's the point? And if I could tell you how many I don't knows or, I don't want to be in DKA or that I get, and no one really talks about the long-term outlook.
Yeah. It's
really common.
Is it so common that it's not upsetting?
It really bothers me because, and it's tough because I'm a peds endo, so it's hard to expect a child to say this, especially if they're younger.
Mm-hmm.
but especially with like the older kiddos, just them not knowing feels like feels like a feels like a big gap in knowledge, and it's that's it's a place where emphasis should be placed, I think.
Do their parents know, generally speaking? Or are you dealing with an entire family of people who just, they're taking the steps, but they don't know why?
I would say, yeah, I would say families as well. I think parents know, they just don't confidently know. So they're aware that they're at risk for long-term complications, but it's typically along the lines of, I'm afraid of, getting nephropathy or retinopathy, so like kidney disease and eye disease, because it happened to another family member, or it's because of, it happened to someone that they knew.
Or
But
I saw it on a television show or something like that.
yeah. Well, and just because it's, you're talking, most of diabetes is type 2. So a lot of people who have type 2, they can even get those complications early on. It doesn't take a long time per se.
Yeah, it's I don't know. Like it just seems to me that even while we're talking about it now, that it wouldn't take me that long to explain type 1 diabetes to a person and why what they need to do is important, and then what those things are. You see it happen. I mean, you're in a position to do something about it, obviously. Like what's the thing that stops it from happening?
I think it's partly because of how we're taught, like as medical providers. But I also think it's part of human nature in the sense of how we think about things. So when we compartmentalize the two types of diabetes, so I'm making generalizations here, but we think of type 2 as the diabetes that's heavily impacted by lifestyle choice and whatnot, when in all reality that's really not what type 2 is. For type 1 diabetes, we effectively remove the lifestyle choice component of it, and we kind of put it in this box of, we take insulin, and insulin normalizes our blood sugar, and that's how we treat it.
Mm-hmm.
That's correct to an extent, because the most impactful thing you can do to reduce your risk of heart disease and whatnot is to normalize your blood sugars. But there are many other aspects in life that impact your risk of developing these problems. I think if we can't convey this, then we're doing a huge disservice to, people who are generally trying to lead healthy lives with diabetes. And they're not going to realize the impact of lifestyle choices until later in life. So it's going to be one of those too late circumstances. But I think on the medical side of things, we do the same thing. So when we're taught, we oftentimes put a lot of emphasis on making lifestyle changes for type 2 diabetes when, and then for type 1 diabetes, there's a tremendous amount of focus on dosing changes and, the technology aspect of things.
Mm-hmm.
And we kind of put the other things, I guess, to the side.
It feels like what you're telling me is that physicians are going to say lifestyle, 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 and that's the last thing that patients are going to focus on.
That's also true. I think it's a harder thing to it's a harder sell. So if you have a short duration of time to meet with a patient, it's going to be very difficult to put a lot of focus on diet and exercise, and mental health is very similar to that. And they're hand in hand, right?
So the way I think about it, and the I guess the footing that I started off on with the podcast was, I thought, well, I know about how to use insulin, and I know the good outcomes that come from it, and I'm pretty good at communicating those things. But here are the things that I can't control. Like I can put that information into people's minds, into their ears, and let them hear it. I can't control what they eat. I can't control if they exercise. I can't control if they're mentally healthy. Like there's so many things that I can't impact. What could I give these people? And I thought, I'll give them the knowledge of how insulin works, and they can apply it to their lifestyle and at least have the healthiest outcome possible, no matter what their lifestyle is. Like, I think that the things I talk about on the podcast would work as well for you if you had 20 carbs a day as if you had 200 carbs a day. But moreover, the idea that you can tell somebody just eat differently, that'll help, and that you should expect them to go home and do that is kind of insane to me. Like, I know they should. I know we all should, but I don't think that's what happens. So I started with, well, let me give them something that's rock solid and concrete. And then they can do what they're adults, or they're the parents of children. Like, they can do what they want to do with that information. And hopefully they'll see the benefit of it and make these adjustments along the way. I very steadfastly do not tell people how to eat. It is not in my purview. I do not care how you eat. It is not up to me. But privately in my mind, if you don't think that I don't hope that you bolus for a cheeseburger and fries with ice cream later and then see what that's like, and then maybe the next day have, something a little more low carb, something a little more, little less processed, less oil, stuff like that, and see the difference. I do hope you see that, but I don't think it's up to me to help you do it. That's sort of how I think about it. But you're in a different position. Like, you get the shit into the stick if people don't have good outcomes, right? Because they're going to blame you at some point. Diabetes comes with a lot of things to remember. So it's nice when someone takes something off of your plate. US Med has done that for us. When it's time for Ardent supplies to be refreshed, we get an email. Rolls up and in your inbox says, "Hi Ardent, this is your friendly reorder email from US Med." You open up the email, it's a big button that says, "Click here to reorder," and you're done. Finally, somebody taking away a responsibility instead of adding one. US Med has done that for us. An email arrives, we click on a link, and the next thing you know, your products are at the front door. That simple. usmed.com/juicebox or call 888-721-1514. I never have to wonder if Ardent has enough supplies. I click on one link, I open up a box, I put the stuff in the drawer, and we're done. US Med carries everything from insulin pumps and diabetes testing supplies to the latest CGMs like the Libre 3 and the Dexcom G7. They accept Medicare nationwide, over 800 private insurers, and all you have to do to get started is call 888-721-1514 or go to my link, usmed.com/juicebox. Using that number or my link helps to support the production of the Juicebox podcast, even though they're the one having the fries and the ice cream.
Well, so I think you're spot on. And it's really, the intention is not to necessarily dictate or tell people how they should be eating.
Mm-hmm.
But in all reality, it's to educate. It's, and even when you look at the diabetes guidelines, like the recommendation is just a regular general pediatric diet.
Yeah.
So, but if I can tell you how many people are not aware of just aspects of eating. So like the differences between food types, be considered a processed food versus a whole food, the impact of protein, the quality of the protein, same with fats, the quality of your fat and how that's actually really relevant. None of that is very well known among, I'd say, most people who have diabetes. As a medical provider, I think that's really how we should approach it, is to teach people. I think similar to many other things that involve behavior, you kind of need to gauge where people are at and whether that advice is welcomed or not welcomed. But I think as a medical provider, it's important to at least broach the subject and at least get a feel as to where people are at, just because of how relevant it is to everything.
Delve into that idea of welcome or not welcome for a second, because I think if I can stand away cold and calculate it off to the side, third person, it's your job to tell me whether I'm going to listen to you or not. But you're dancing a different dance, because if you lose the group, how was I going to put it? It's like you're a head coach. If you lose the team, if you lose the locker room, you lose the team. So if you come at somebody the wrong way and build a wall between the two of you, you might never get that wall down again. But if you don't broach the subject, they're going to end up having trouble. And so you're left to decide how to deal with that. And I want to ask you your opinion, but it's been my experience so far. A lot of times the brain that makes a good doctor is not the same brain that makes a great communicator. Is that fair?
I think that's true.
Okay.
But I mean, someone walks in to the office, right? You have half an hour with them. that entire half an hour is not going to be about eating or activity, or you're not going to know exactly where they're at in life. You don't know what their stressors are. You can certainly get a vibe for it. It's kind of part of your mission. You kind of need to figure out, is this the right time? What's the level of interest? Someone willing to actually share their knowledge about that particular subject, and then really give them what they're ready for, what they're asking. If they're receptive to feedback, we see this oftentimes in kids that are active, that are involved in sports. They're coming to you with questions. That becomes a theme of the visit, because the next time they come around, something else might be happening. It might not be a priority. So I don't know. I think that's a really good way to kind of attack it from that perspective.
Is it possible that the medium that I have to speak to people is just better suited to disseminate this information than an office visit or a doctor-patient relationship?
Yeah, hands down on the table. I mean, it's just like what I told you about myself earlier. Like, I needed to fill knowledge gaps, when I got diagnosed. So I went ahead and sought out information. I was ready for that information. I wanted to learn. So I think that's one of the pros of, a podcast or a book or, an online article, whatever, is that you can seek it out when you're ready.
Yeah.
But I think, but even as a provider, we can still get a vibe as to where someone's at in this conversation and potentially provide these resources. So I think there's a difference between going and seeking it out yourself versus, being able to provide information when someone is actually ready for that, or if they're interested in it.
Yeah. Is it possible that maybe should be communicated to a person? The kind of idea that, look, there's this information here. You need it. If you have it and understand it, your life is going to be happier and healthier and probably easier. But there is no way for me to rush you to the place that you need to be to absorb all this, to want to absorb all this. I need you to know that it's here. I need you to know what it is. And I'm willing, as your physician, to sit back and wait for you to be ready to take it up. Because that's the truth, right? Like, that's how, you've described it. I've seen it here for 1,100 episodes and all the conversations I've had. This is exactly right. People do not take care of themselves until they're damn good and ready to. And often they won't do it unless it's for someone else. Like, I'm getting married, I want to be healthier because, or I'm pregnant, or I want to have a baby, or I want to be around for my family, or I saw this thing happen and I don't want that to happen to me. Like, that's generally speaking how most people make the leap. Maybe it's important for them to know that this is a very human reaction they're having right now. I know you don't want to hear about pre-bolusing. I know you don't want to learn that, the French fries have fat in it. It slows down your digestion. And therefore, you're going to spike like 90 minutes after you eat them. And you're going to think, I don't know what happened. I already covered the carbs. And, they need to know all of that stuff. But is it not maybe incumbent upon us to tell them? Because as far as humanity goes, I don't know that we know a lot about ourselves. Like, you can stand back as a physician and say, I know how this is going to, as a matter of fact, I bet if I said to you right now, think of a patient that you don't believe is going to do well, these people start popping into your heads. You know what I mean? And then there's probably people who you think, oh, if they just make this one leap, I know they're going to do better. I bet this person figures it out when they're in college or when they become, I'm sure these people all present to you like different parts of this path. But we don't know that about ourselves. Like, you know what I mean? Like, you always need somebody to tell you who you are. It's hard to figure it out for yourself.
Yeah, I agree. And I think it's more so, it's almost like a reminder, just like how you get spam emails, advertisements that pop up, like stuff like that just triggers you mentally. Mm-hmm. So I think if you engage in conversations repeatedly, your interest kind of shifts. And it's part of that is based on life circumstance, what your personal goals are. But also, if it's on top of mind more frequently, I think it's more likely to change. It's very similar to smoking. So if you think about people who smoke, the more you ask them about quitting, engaging where they're at, the better that they typically do. So I think it's kind of similar.
Yeah.
I don't think it's remotely close, but kind of the same.
Well, it's actually fascinating that you brought that up, because as you were talking, I thought, if the conversation keeps going the way I think it's going to, I'm going to make a joke that we should get those PR people from the 50s who sold cigarettes to everybody and retask them with teaching people to pre-bolus or pay attention to like that their foods are. I actually thought that like, let's get great marketing people to tell us good things that we need instead of the bad things. Maybe that would work. You know what I mean? Like there's something to that. I mean, there really is. Like you said, you have to hear it over and over and over again. I've learned from making the podcast that even just getting someone to click on a link is an excruciating task. Like you have to first tell them that the link exists and explain to them what it is. And then sometimes you have to do that sometimes up to 10 times before they remember the link and then think, oh, okay, maybe I'll check it out. And that's just how we work. And so it makes sense. You know, it's interesting because I'm doing these two series at the same time. And, you know, you and I spoke about this before we started to record because we weren't 100% sure and maybe still aren't which series this episode belongs into. But I'm doing this Grand Rounds thing, which is it's aimed at doctors to tell them, look, this is what people who have type 1 diabetes want to know. It's what they told us they wish somebody would have said or how they would have said it, etc. Here's the reasons why, you know, and Jenny and I are going through and discussing all of them. And at the same time, I'm doing another series called Cold Wind, where people are coming on, healthcare providers, other professionals, completely anonymously, and they're basically blowing the whistle on what they see at their jobs. And as I'm recording these episodes, I am stuck in this paradox where I both find myself vehemently defending the doctors because they seem like they're in an impossible situation, and at the same time defending the patients because these doctors are the only thing that they have. And it's a situation that I don't like. The more conversations I have about it, the less answers I see, the fewer answers I see. My wife would be so upset if she heard me say less answers, the fewer answers I see.
Same.
But you know what I mean? Like it's you're the one they're counting on, but you're in a human situation that's almost unfair to ask of you because it's probably not going to go well unless they're in the right place to receive the information and then put it into practice.
Yeah.
Yeah. So what do we do?
It's one of those things where I think you just, you keep pressing. You don't want to press too hard. You want to give them, you know, information that's relevant to them at that moment in time. I think that's all you can do. I mean, really the other thing that I've personally seen that helps a lot is, and I think this goes to human nature, is that we learn from each other. So there's a big difference between telling someone to do something or even effectively planting an idea versus having someone learn from an experience or like a role model.
Yeah.
So as an example, like I do diabetes camp, and I can tell you how often things change when, you know, children interact with other children who have diabetes. And it's not just from a dosing perspective. It's all the other behaviors that go into diabetes. It's all the other coping, you know, mechanisms that you have to basically, you know, feel normal in your skin. That's not from anyone telling you anything. It's from seeing other people do the exact same thing, see them succeed, see them fail, see them get mad. So I think that's really valuable too. Unfortunately, in the office, we can't offer that. So I think that's where, you know, being engaged in diabetes outside of an office becomes really, really important. And I think it's eerily similar to things like your podcast, because it really does give a sense of community. And I think that's a way that we learn as humans, is to kind of emulate and, you know, mimic other human beings.
Right. You know, I've said this a number of times in the podcast, but I feel like it fits here as well. There's times when I think there should be mass appointments that are management specific. Like not every time you come in, but what if twice a year or 3 times a year, you guys did seminars instead of, you know, and I know it turns into a billing issue and an insurance issue and like all this stuff. Like it's the doctors don't have time to do it. But I've given talks like to hundreds of people at a time and then received back emails from a large portion of them saying, hey, I did better the week after I heard you speak. Yeah, I don't even know why. I couldn't even begin to tell you what I did, but we talked about diabetes for 2 hours and my blood sugars were better the next day. I think that's important. And I don't think people, like, it's nice to say, that you went out and found the information, but you're who you are. And there are plenty of people who aren't going to go. They're going to hear, count my carbs, shoot the insulin, drink a juice if I get low, don't be high for too long because I don't want to be in DKA. That's it. And they'll do that every day. They will not change. They won't wonder about if there's more. They'll think that's the whole game. If their health gets bad, they'll say things like, well, that's just diabetes, or, it's my lot in life. It happened to me. Never thinking like, this is a thing I could impact. And not like with information that's so hard to get or tools that, I can never find. Like, you just understanding how insulin works, you can make a significant dent. Like, I say it on the podcast because I want people to hear it and believe it, but just pre-bolusing your meals could bring your A1C down a full point. Like, just that, without even understanding the rest of it. And yet people won't wonder about that. And it isn't until they get into a terrible situation and go out to find a thing that they even hear some of these ideas. Like, you have no idea how many notes I get from grown adults who have had diabetes for 20 or 30 years they're praising me in this email on and on and on. And when I get to the end, what are they praising me for? I taught them to pre-bolus their meal. They had 30 bad years because they didn't know that. Like, that's insane.
Yeah. Yeah.
I'll say it again. I'm not sharing any special knowledge that I have that the rest of the world doesn't have. I just found a way to communicate it in a form that people can take up easily. And I've scaled it, which, if you're looking for things I'm proud of, just scaling the podcast is a big deal. Like, I was back, I'm like, oh, I'm helping 10 people. That's really amazing. Like, this, but a lot of people don't know the feeling of helping 10 people. It's amazing. 100 people, it's amazing. It doesn't really change. The good feeling, whether you help one person, 10 people, or 100 people, it's exactly the same. But once you realize that you have this knowledge that changed someone's life for the better, I almost get into a panic. I'm like, well, how do I reach all the people who need to know this? And so I put a bunch of effort into scaling. And all it did was prove out over and over again that this basic kind of baseline information communicated well helps people on a mass scale. How do we get that to them in a doctor's office? Because most of them, believe it or not, are never going to find the podcast. Listen, here's what my question is. You're diagnosed when you're 18, you're already on your way to becoming a doctor. Did you become an endocrinologist because of your diagnosis?
Yes,
okay.
Basically.
All
so
right.
I was going into medicine at the time. So I did kind of like I'm going into med school knowing freshman year of college.
Mm-hmm.
I didn't know what type of physician I was going to be. And then, it's kind of threw me in the door.
Can I ask you a cultural question that everyone's not going to understand, but you will, and some people will?
Sure.
Did you want to be a doctor?
Oh yeah.
You did.
Hands down on the table.
This was not a family thing where you're going to go be a doctor.
No.
Okay.
Both my parents are like math people and statisticians, and
Mm-hmm. You know why I'm asking though, right?
Just because most physicians have family members that are doctors.
I was actually thinking culturally, I see a lot of you're going to go be in medicine. Like, that's a good paying job. It's a respectable job. Go be in that job. And I know a lot of kids who are currently trying to be nurses and doctors who don't want to be, but their parents pushed them in that direction. I was just wondering if you were pushed by parents or if it was a thing you actually really wanted to do.
No, I wasn't pushed by anyone. And actually, it's kind of funny. I was given advice not to go into medicine because of effectively the commitment and the debt burden and
Mm-hmm.
the high risk of not making it through the entire pathway and getting stuck with that. But I think, at least for me, just mentally, I'm a very sciencey, type of person. I geek out on technology. So just by nature, I needed to be in a science field.
Mm-hmm.
And I was originally planning on doing computer science. And I actually did web design for a short bit and quickly realized I did not like it when it wasn't for fun. So then, that's how I basically landed.
Okay. Oh, that's amazing. Are you more of a people person doctor or a medicine, or do you try to straddle the middle?
To be honest, I don't know what that means.
So I think some doctors can lack people skills but still very passionately feel about what they're doing because they love the medicine of it. And I think there are some people who just want to help people and they've learned the medicine so they could help the people. Does that make sense?
Yeah. I don't know. I don't necessarily think I do well with people. Like, in other words, I probably not well said, but it's more so that in general, I'm typically laid back. And I think, through a care perspective, that also shows. Like, I'm pretty conversational. Really, my intention is to walk in, get to know you as a person, that type of thing, and troubleshoot things that are meaningful to you. So I don't know, that's how I roll.
Mm-hmm.
I've just taken my experiences from past medical providers, and I basically figured out that that's how I vibed well with others. So I try to do that.
Yeah. I think if I was an endocrinologist, I've never thought about this before, but just now it started running through my head. I think if I was an endocrinologist, I would be like of the camp of like, listen, we're all going to like talk and be nice and be friendly and everything. But by the time a year goes by, you're going to know how to handle your insulin and your meals. And then we'll branch out from there. If you want to go talk to a therapist about how you feel, you should do that. If you want to talk to a nutritionist, you should definitely do that. Here are all your other options of things that you could be doing. But in this office, we're going to talk about how to functionally use insulin so that you have outcomes that are repeatable and desirable. Because I think it's like teaching somebody to throw a baseball. Like when you show up, you're pretty young still. I don't know. Do you have any kids?
Yeah. 2 girls.
Oh, 2 girls. Okay. So
they're awesome.
Excellent. So you go out there, the first time you try to get those girls to throw something to you and their elbow flies the wrong way and the ball goes 8 feet to the right and everything. And it's demoralizing. You can see it on children's faces. Like, oh my God, I can't even get this done. You know what I mean? And then you teach them technically how to do it. Whether they love softball or baseball when it's over or not, who cares? What you can see is the confidence that comes from picking that ball up, not thinking, and putting it where you want it to be. And I kind of think about the diabetes like that. Like, I want you to be able to, no matter what your situation is, to be able to pick up that ball, throw it, it goes where you want. And then you have a tool. Like, you have an actual skill and a tool, and you can go put it to work wherever you want. And it comes with confidence. And I think that once you have that, then the next meal, it's a little more difficult, or the high blood sugar that, doesn't come down. And at first you're like, there's no reason for this. You can actually step back, apply your knowledge and your tools to it, and come up with the reason why, fix it, and move on. And I don't know, I just think that would be the way I would roll. I've seen it happen. I've seen people send graphs and they're out of their minds. Like, you can sometimes read in an email a person who's about to like just flip out. You know what I mean? They're like, they've done that. They've beat their head against the same wall over and over again. Nothing's changing. Their diabetes is not where they want it to be. They feel
all
like
caps,
it's
exclamation marks, emojis.
Oh my God. Yeah. They're just like, I need help. Like, and by the way, that a person needs help when they're writing to a stranger that they heard on a podcast. Like, that's when you know somebody's in trouble. You know what I mean? Because there's a lot of like leaps in there to make, and then I don't know them. I don't know their trials or tribulations. I don't know their IQ. I don't know their financial situation. I just go, you got a pump or no pump? What insulin are you using? You have a CGM? You do? Can you show me a graph? Great. I see a 24-hour graph? Great. This looks like you don't have enough basal. This looks like you have too much basal. Looks like you're not pre-bolusing your meals. Are you pre-bolusing your meals? You're not? You should try that. Have you basal tested? No? Well, I see you seem real stable, but you're stable at 180. Let's get your basal right. And it doesn't take... I just did it with a lady. I don't know her. She just sent me a graph. Like, she panicked, sent me a graph like through a direct message. I think I messaged back and forth with her for 4 days. And like 5 days later, her doctor was like, my God, how did you fix all this? And she's like, I messaged a guy on the internet. like,
that's awesome.
Yeah, but I didn't tell her what to do. Keep in mind, I asked her questions and I let the answers that she had inform what she thought she should do next. And if she wasn't sure, I'm like, what are you thinking? And she's like, I think it might be basal. And I'd say, I tend to agree with you here. And she said, how much should I move it? And I said, I can't tell you that, but I can tell you that based on your kid's weight, I think he needs about 22 units of basal insulin a day. But she was at like 16. I was like, don't just like crank it up to 22. Just know that I'm thinking that the high end of the possibility is 22, but let's go slow. It took her like 3 days to fix it. Once she had the basal right, boom, everything was like magic. And then she went back, looked at her carb ratios. she started having these thoughts about like, oh, I was covering for my basal with the boluses for the meals. And because I said to her, now that your basal's right, be really careful at meals and corrections, because the way you do it is probably now maybe a little heavy handed. So let's be careful of that. And if that ends up being so, then let's reevaluate those things too. But I'm telling you, they're back and forth in a DM with a person I don't know. And it's not maybe more than 15 times back and forth, and everything's fine now. So like, when that's possible, can you see why people are upset and why they say my endo doesn't help me?
Yeah, I think that's a struggle in general, and it's hard. I oftentimes feel that's because a lot of people are also overwhelmed with everything that goes into diabetes just in general.
Mm-hmm.
And when that happens, there's oftentimes no conductor. So good example is, patient, is newly diagnosed at the point where they want to start pursuing tech. They're reading about CGMs and insulin pump therapy and automated insulin delivery. And, 90% of their time is going into figuring out how to obtain these, doing all the necessary trainings and education. Finally, they have everything in hand and they're like, oh, wow, I have like 2 apps I need to look through. I don't even know which one I need to look. And
people can be overwhelmed.
Yeah, like one doesn't go to my phone. So a lot of the same kind of behaviors that would go into injection, kind of the simplistic, basal testing and whatnot. People are hesitant to kind of rediscover that. I don't know if that's the word, but so there's a lot of hand holding, at least what we do in our clinic. And I think it works relatively well.
Mm-hmm.
I'd say that it doesn't work for some, but we typically we put strong emphasis on gauging where they're at, like glycemic control.
Yeah.
And then we teach pattern recognition. So we basically tell people, all right, remember, you effectively have a bolus and a basal dose, and you're running high post-meal. That's oftentimes reflective of your bolus, et cetera. And then we effectively try to connect dots so that if they understand that they're not in range, they can go and see where they're running high to effectively understand what dose change needs to be made. And I say it this way because some people they will never feel comfortable changing their own dose. Although we are huge proponents of doing that, like literally the last diabetes ed class that we talk about is to effectively empower people to change their doses to whatever comfort they have. I think that works really, really well because it effectively tells people, all right, this is the goal. This is where we want you to be. This is what's going to minimize, your risk of complications long term. This is how you go and look for highs. And then this is how you're going to identify if a dose change needs to happen. And then they reach out to us. And then eventually, once they start reaching out to us, regardless of the degree of help they need, that's when we can basically layer on top of that. We can talk about, bolusing strategies, split bolus, timing of insulin, impact of certain food choices, how to, cover proteins and fats. And
yeah, when they know how to keep adjusting their settings so these things actually have a shot at working.
Right.
Because a lot of times they know the tools, but their settings are so off, they still have bad outcomes. And then they're like, it doesn't work.
Yeah.
Like, yeah, I tried to do a temp basal, but it didn't work. Well, your basal's 0.5 an hour. It should be 0.9 an hour. Temping it up 10% isn't going to change anything. It's 40% too weak to begin with. So for me, again, I think it's, you teach them how to get their settings right. You teach them how to make adjustments. And I know this is going to sound silly, but I think most people listen to this podcast know how to adjust their insulin because I say, if your blood sugar is too high, you don't have enough insulin. And if it's too low, you might have too much insulin. It's just that kind of stuff that's so simple that a doctor wouldn't say because there's, 8,000 caveats that go along with that. And you don't have time to explain them all but the truth is that's about right. If you're high all the time, you don't have enough insulin. Like it's not like turning it into something that sounds like, oh, the problem is your insulin to carb ratio might be off. Like, great. You just lost people. Your insulin sensitivity. By the way, when you start telling people insulin sensitivity and then turning the number down makes it stronger and turning the number up makes it weaker, I think you lose people there too.
Yeah, and then the next sentence you say correction factor, and they're like, "What?"
Yeah, what do we? I don't know what we're talking about, and that's why I don't talk about it that way.
Yeah, no, you're 100% correct.
Right.
I mean, like, exercise is probably the best example of what you're saying.
Mm-hmm.
Like, if I can tell you how many people walk in and they're like, "All right, I keep going low during activity. My doses are off. And then I tell them the reason you go low is because of insulin. You know that, right? Yeah. And they're like, oh, yeah. And then finally it clicks. They're like, oh snap! I took in 6 units of insulin an hour ago for lunch.
Yeah.
That didn't even cross my mind that I had insulin on board.
Mm-hmm.
Yeah, but perfect example of people just need to be told that this is what insulin does.
Yeah, you want to exercise, don't have active insulin going, and you're probably going to be okay.
Yeah.
If your settings are right, by the way. If you're, by the way, over basaled, because is that a thing, will you admit to? Do endos over basal people because they're afraid they're not going to cover the food well?
Oh, yeah, absolutely. Mm-hmm. And I think, we see that less because most people are on AID now.
Yep.
And, with a significant portion of AID, you kind of lose control of that even. But yeah, we still see it. Do
you think automatic devices and, something paired with a CGM that's making an insulin decision for you, do you think the greater the prevalence is with them, do you think the less people are going to know fundamentally about their diabetes? Do you think they're just going to lean on it and say, I'll just let this thing do it?
I don't think so. And medically, there's evidence to suggest that that's really not the case. So they've put insulin pumps on newly diagnosed patients even before learning how to do injections. And they were effectively taught injections kind of like after the fact, kind of on an as needed basis. And those people do well, and they do, arguably better. Not necessarily the right choice for everyone, but the point that I'm making is that you might be losing a skill. You might not be taught a particular skill that could potentially be valuable, but getting it taught later might be a reasonable idea.
Yeah.
So I don't think so.
I'm glad to hear that.
I think the superiority of the devices are really evident. So taking it away from someone with the intention of, quote unquote, teaching them how to drive a manual car, I think is kind of silly.
I find it to be an old idea as well.
Yeah.
I'm just worried that if something becomes so automated that if you took it off them, they wouldn't know how to help themselves. I do think that's true. I mean, I look at my daughter's basal insulin, overnight last night even, just absolutely the algorithm took her basal away for an hour and a half, and then it gave it back. And then it almost immediately was like, oh, I shouldn't have done that, and took it away again. Right. So that's not a thing that if you just go back to shooting Levemir, for example, or Lantus or Tresiba even, that's never going to happen. And they're not going to know because they're going to think, well, when I was on a pump, everything worked. And now I'm injecting it doesn't work anymore because they don't see the impacts of the insulin. And that's, again, why I'm going to go back over and over again. I'm going to sound old at some point. If people don't know that basal is first, and without a good basal insulin, you're lost. And they don't know about their ratios, and they don't know how to attack different foods because those foods have different needs, they're never going to understand what they're doing. And it's going to be a problem even on an automatic system, because if you don't know how to bolus for something, if you look at Chinese food and say, oh, this is 50 carbs, and think it's going to be the same as bolusing for, another thing that's not deep fried, doesn't have sugar on it, and isn't like breaded, but is also 50 carbs, you're going to be confused forever because you're going to say 50 carbs, 50 carbs. Why didn't it work the same? Because of all these different impacts on your digestion and all these other things that no one talks about. But it's not that hard to talk about in a way. You know what? These conversations, they depress me and they get me excited at the same time, because part of what I feel like we're saying is, if you get lucky enough to find a doctor who understands and can communicate it, you're probably going to be okay.
Yeah.
But what if I don't get that?
Yeah, I'm going to add to that, because I feel like part of the benefits to these types of conversations is that it's empowering, right? So if you go and you slam Chinese food and, you run a high blood sugar, you're going to feel defeated, and you're going to feel like your treatment isn't working and you're failing and all that. So if you can give people pieces of knowledge to effectively really take the reins and take control over their diabetes, then I think that makes it very empowering. So if you're able to make decisions about how you eat and how you dose and have a good outcome after that, you're going to want to do it again.
Yes.
because you know you're not going to wake up in the middle of the night treating a low. Good example. That's actually a great example, right? Like, for example, if you're going to go into eating Chinese food at like 10 p.m. with like a bazillion units of insulin because you inflated the dose, knowing that your blood sugars are going to get demolished, but then you deal with a low. If you chose to maybe ate that Chinese food a little bit earlier in the day, so you didn't have like an evening low, you're going to feel awesome about that. Because you made the choice, you thought it through, So I think that's the value of talking to people about insulin as well, is that it really changes attitudes around really what's happening versus, here's a machine. I hope you fare well on it. And if you keep typing numbers in it, you should do okay. That's really what would happen if you didn't have these conversations, right?
Yeah. No. Yeah, I would tell you that one of the bigger surprises for me when I start, this podcast I'm in my 10th year right now. So I've been doing it a long time. But when I first started doing it, I thought, well, I'm really good at insulin. I'll explain it on the podcast. And that's what the podcast will be. And it has been very beneficial. I think anybody who's heard the Pro Tip series or the Bold Beginning series for really newly diagnosed people would probably agree with that about the value of it. But it's the conversations that really just, supercharge it. And I did not expect that. I really didn't until I started having them and listening and thinking there's a ton of value here. Like I'm talking to a 24-year-old person. I'm thinking of a conversation I had recently, this 24-year-old girl, and she struggles. It doesn't go her way. And she's real active during the day because of her job. And she's got a little vacillation in her, and you can hear in her voice that she's beaten up. You know what I mean? Like she's fought one too many wars and they haven't gone her way. But at the end of the conversation, she's invigorated again. And that's great for her, but that's not really the way I think about it while I'm talking to her. Like, I'm happy to have a conversation with her and I am speaking directly to her and about her. But in the back of my mind, I'm thinking tens of thousands of people are going to hear this and they're going to think, oh, that's what's happening to me. And then they don't feel as alone. And then it feels more possible. That's the kind of stuff that we can't value that enough. And it's almost impossible to explain to a person the value of it. You know what I mean? Like, I've tried to tell somebody, you don't know, go listen to this. Like, just go listen to somebody talk about what went right for them or what went wrong for them. It'll help you, it'll enrich you. And some people look at you, a lot of people look at you cross. Like, hearing someone's story is not going to fix my low blood sugar, but it is. It actually will. It's not a thing I expected. I didn't realize it when I started doing this. I also don't know how you're supposed to do that as a physician either.
I think this goes full circle, right? We were just talking about, experiences in terms of, counseling, people who have diabetes. It's just like camp, right? Like that's how we learn as humans. There's a difference between being told something and experiencing it with someone or learning it from someone in the sense of hearing a story. Like, I think that's the value of those types of things. So I think it's just, we're back to where we started.
And you can do that purposefully. And I'm going to pull the curtain back a little bit. It's almost an hour you and I have been talking. We didn't come full circle by mistake. You understand?
Yeah.
Yeah. I do this for a living. But doctors, you do it for a living too. You do your thing too. Like, be purposeful about it. I had a real honest conversation for the last hour, but at the same time, I had half a mind on not just having the conversation, but leaving it behind for other people to follow as a roadmap. And I think that's it. I think you can do that. I'm going to just come out and say, and I hope the doctors don't take this the wrong way, I'd be a terrific endocrinologist about diabetes. I'm sure I don't know anything about anything else. Although I'm not bad with thyroid stuff. I have a lot of thoughts about anemia that I think are valuable. Also, I think I'm on the side of GLPs, by the way, and what they're going to do in the next 10 years for people. That aside, I think I could do your job. I actually think I do it every day. I do it in small chunks in personal conversations, and I do it in bigger chunks by teaching myself from other people and learning how to talk to the next person because of that. And you have to make some generalizations when you do that. That's not a bad thing all the time. Like, you don't want to generalize, put somebody in a box and be wrong about them, obviously, because that's a disservice that's pretty infuriating. But I mean bigger generalizations, like people forget to pre-bolus, or people forget that they have diabetes, or they don't want to be bothered by this. Some people don't want to think about it. Some people, it's like, so talk to that person that way. Like, here's how you can, that's how I tell my daughter. I'm like, you don't want to think about this? Do these things. And then you won't have to think about this otherwise. Because my daughter's not one of those, like you guys have like heard Jenny talking. Jenny is a healthy person. She eats healthy on purpose. I once asked her, when you go on a road trip with your family, I'm like, where do you stop to eat? And she goes, we don't stop to eat on a road trip. I was like, what the hell? How do you eat? And you know what she said? She brings food with her. I was like, God damn, I never thought of that. And then I was like,
why would you do that?
Oh my God, well, you could get like a Milky Way bar at the store. And I'm like, oh, she's an actual healthy eater. Like, she would never stop at a gas station. Like she just wouldn't do that. So when you're talking to Jenny, you talk to Jenny about who she is. When I talk to my daughter, I talk to my daughter about who she is, right? My daughter's not a person who wants to be involved with diabetes, but she also wants to be healthy. If you ask her personally, and I say, why do you do this? She'll go, because I don't want to die. Like, she's motivated by her own health, about the longevity of her existence and her ability to do the things that she wants to do while she's alive. She doesn't give a shit about diabetes. When I try to explain something to her, she's like, I don't care. And I'm like, I know you don't, but this part's important. And she knows if I go, this part's important, she stops. She's like, he's going to tell me something I actually really need to know. If I start telling her something that's extraneous or like the geeky stuff that you enjoy, and actually, I guess, oddly enough, I enjoy. By the way, how weird is it that anyway, she gets lost. She's like, don't care. And I'm like, okay, so I don't bother her with that stuff. I gave her the tools she needs. I gave her the knowledge she needs. Could she have more? She could. Does she need them? Not right now. That's how I put her. I mean, my daughter's A1C. She just left. She just went back to college. She was home for like 7 weeks. In the 7 weeks she was home, her A1C was 5.6. Right. And that's her managing herself completely by herself. And when she was,
that's awesome.
Oh my God. When she was in college, the first year as a freshman, I said, just do the things you know how to do. She struggled a bit because the food was crappy. Now, when I say that, processed and fried, okay? Just when you hear crappy, hear processed and fried, not real ingredients, fried food. And she was using insane amounts of insulin. And I don't mean insane like the number, I mean versus what she would have used at home eating the way we eat here, which is not like super clean or anything like that. It's just much better. But she stuck with it. She did not give up. And she came home with, I think, a 6.5 A1C after her freshman year. All I did when I saw how bad the food was and how it was impacting her is I told her, look, above all else, pre-bolus and don't stare at a high blood sugar. Do something about it. Those are the two things I told her, and she came home her freshman year with a 6.5. Now, she left with a 6.1, I think. But okay, bad food, different variable. We fixed it. She came home. I said, what fixes this problem? She said, if I had my own place with a kitchen, I could eat better. We petitioned the school. We got her a place to stay that had a kitchen. She came home the next time. Her A1C was 6.1. She got it back down to where it was before she left. Then we got her home, and I watched it come down a little bit, but she was fighting. And I said, she's just like a longer story, but we think Arden probably has PCOS, right? So she sees a little bit of insulin resistance, tough periods, acne, stuff like that. I don't sit back and go, oh, well, that's her lot in life. I get in the game and I figure that out. So right now, and I think this is the first time I'm saying this on the podcast, Arden is shooting 0.25 of Ozempic a week. Just that. She's never going to titrate up. It's going to stay just like that. Her basal went from 1.1 an hour to 0.7 an hour. She's using 7 units less insulin a day in basal. And based on her total daily insulin, I think it's completely possible that in 2024, Arden will use 11,000 fewer units of insulin for 0.25 of Ozempic once a week. And I don't know if that's right for everybody. I don't know if you can get your doctor to be on board with that kind of stuff, et cetera, and so on. I just tell the story to tell you that when I see a problem, I fix it. And I tried to explain to Arden what the Ozempic did, and she went, okay, I got it. And then I tried to get a little deeper into it, and she went, I don't care. And I was like, gotcha. And so I didn't burden her with more. But if she sees it helping her, like she's seeing it, she'll keep doing it. So I don't know. And I don't know where you fall on that, but I think GLPs are going to become, as soon as insurance companies pull their head out of their formulary ass, you're going to see GLPs for type 1s pretty quickly.
Yeah, I use it situationally, and it's amazing. Like, there are people that are just insulin resistant, and it's really evident.
Mhm.
And wow, just a whiff of almost any GLP-1 will help.
It's insane.
Yeah.
Like, I mean, honestly, I'm about to interview the mother of a little girl. I think she's like 12 or 13, who's had type 1 for 3 years and is now not even using basal insulin anymore because of she got put on Wegovy for weight, and her insulin needs just kept dropping and dropping and dropping. Yeah, I'm not saying it. You understand, kids got type 1 diabetes, I'm sure at some point, but it turns out this child might have been in like an extended kind of like LADA situation, that this was enough to help along the way. I mean, it's fascinating stuff. I mean, the reason we started Arden for it was, the really painful, long and excessive periods and the pain in the stomach. And we got on that. My wife was on a Facebook group for GLPs. And she said, Scott, I keep coming, every time I come back, it's a new woman who hasn't been able to have a baby for 20 years, is pregnant on a GLP medication. And I'm like, get out of here, really? And she's been telling me about that for 6 months. I started Googling it, and there's already some testing going on that women are just like, who could not get pregnant before, are seeing like pregnancies on GLPs. And that spurs more conversation that tells you like, oh, I'm taking it for PCOS, and it's really helped with my PCOS symptoms. And I'm telling you, Arden's acne cleared up 80% on it. It's, and I don't think, we're not sure where her dose is going to be yet. So I'm not sure that we're there yet on where it's going to be, but her acne cleared up 80%. Her insulin needs went down the way I just explained. She lost 10 pounds and she just generally looks better. I don't know if this is a little weird, but I saw a thread on Reddit, and hey, Reddit, I appreciate how cool you guys are about the podcast. Thank you. I saw a thread on Reddit where people with, I'm going to mispronounce this, Ehlers-Danlos. Can you say that for me?
Oh yeah, Ehlers-Danlos.
Okay. There's a whole group of people that have that connective tissue disorder who are saying that a lot of their symptoms went away on a GLP medication.
Huh.
Yeah,
I don't know if I saw that. That's insane.
I'm on the internet. And so, I don't know if look, who knows if that's a real thing? Maybe they have it and they were heavier and they lost weight and it's easier on their joints. Like, I have no idea what it is, but like, that's the kind of like thing where the community stuff really does help, because like someone hears that and goes, maybe I should look into that. Like, maybe I should find out about this pre-bolusing thing. You know what I mean? Like, and I don't know, to me, I appreciate this conversation greatly, but in the end, what I hear is the model that's set up right now works great for some things. It doesn't work great for type 1 diabetes in a doctor visit with a physician. Like, there's not enough time. There's too many variables. There's doctors who aren't great communicators. There's doctors who don't have a lot of good information. There's patients who aren't good communicators, patients who are not interested in doing well for themselves, and everywhere in between. And with all these different variables, how can this static system work? It'll work for some people and it won't for others. And that's just what it's going to be. You're a smart young person who has type 1. I didn't hear you go, oh my God, I have a great idea. Let me tell you how we can fix this.
Well, I mean, the way I look at this is that we're effectively like cheerleaders. So I was going to disagree with you at one point.
Please do.
And that is, we will never ever know the person who has diabetes as well as they know themselves. Mm-hmm. We will never understand the child, and the parent will eventually know more about their child's diabetes more than us. So we are effectively like cheerleaders. What makes us useful to most people who have diabetes, and I say us as in like endos and other diabetes care providers, is that we see the gamut. So, we're a clinic of close to 2,000.
Yeah.
We see the stupid. We see every walk of life. We can kind of get an idea of what would be average, what would be an outlier, and we can kind of augment the person's expertise in their own diabetes. So I think as a medical care provider, that's how we become valuable. So I think you're right. You can you know diabetes just as well as, any endocrinologist. It's just you probably don't see, you know, as as many different people as us. Well, for you, because you have a podcast, maybe, but
I don't disagree with you, because I do find myself wondering, because I do work in a room. I don't actually see any of the people I'm talking to. Am I just attracting, and I'm sure you could think this, am I just attracting a certain segment of the population who works well with what I'm doing? And that's completely possible. And if that's the case, then I'm happy to help those people. But I would share this, is that if you've ever heard the Pro Tip series, at some point in the Pro Tip series, you'll hear me describe pre-bolusing as a tug of war. I don't know if you've ever heard me say that before.
Yep.
And the explanation has been told back to me by clinicians and people the same, that it's the clearest explanation of bolusing insulin they've ever gotten in their life. And I came up with it on the fly, a long time ago, maybe over 10 years ago, because I used to be this person who wrote a blog. And once in a while, someone would get on Facebook and have a problem, or somewhere online and have a problem, and someone would say, you should find this guy, he can help you. But back then, what that meant is like they'd call me on the phone and I'd be like, hey, what's going on? And we'd talk for 30, 40 minutes, and I'd hit, what I think of as the most important pieces that would kind of get them going in the right direction, hopefully let them find their own path. But I was talking once to this very young girl. She was in her early 20s, but she had a baby that was already 4 years old, I think. And it was clear to me she had dropped out of high school to have her baby. She was waiting tables, and, I don't think she was, I hate to say this out loud, but she was not the brightest person I'd ever spoken to in my entire life. I guess I'm just going to come out and say it. And I explained basal insulin. I think she got that. I explained bolusing, and she was concerned enough for her child to stop me and say, I don't understand what you're saying. And in that moment, I recognized I was either going to tell her I couldn't help her, and she was going to go struggle for her whole life, and that baby was going to live with an A1C in the 8s and 9s, or I was going to find another way to say it. And I said to her, have you ever been in a tug of war? And she said, yes. I said, you can picture the rope with the flag in the middle? And she said, I can. I said, okay, well, instead of like one team on one side and one team on the other side, and the goal is for one team to pull that flag on their side and win, let's imagine that on one side of the rope is carbs and on the other side is insulin. And the new goal is for the flag never to move. And then I just explained it from there. And I got done, and she said, I got it. And I was like, oh, it's terrific. Thank you. And like months later, I get a message from her. She now has my phone number, right? So I get a text from her, can I call you? And I'm like, okay. So she calls me, and when we say hello, she's crying. And I swear to you, my first thought was, this is a really long time ago, my first thought is, God, did I say something to her that caused a problem? I'm like, are you okay? What's wrong? And she just says, thank you. I want to thank you, through tears and choking and snot and crying. I want to thank you. I'm like, what are you thanking me for? And she says, my daughter, she's sitting on the floor playing for the last hour, and this is how I remember her from before the diabetes. And I was like, then I'm crying, and I'm going to cry now, actually, if I'm being honest with you. And such a real memory for me. And I said, why? I had to break it up because it was too much like actual emotion. I was like, what are you calling me for? Tell somebody else. She's like, no, she's like, you did this. And I stopped her. I said, I didn't do this. You did this. I just told you how insulin works. And we chatted for a little while, and we got off the phone. That was it. She said my daughter was sitting on the floor playing for an hour or more. Her blood sugar never got too high, never got too low. She kept saying, like, you should see how steady it is. And I was like, yeah, I know. Like, that's how it works when you have your stuff right. And she's like, but everybody told me she was brittle. And I said, yeah, that just means you weren't using the insulin correctly. And I think older type 1s would disagree with this, but I don't think brittle is even a real thing.
I hate that word.
Yeah. I think just people don't know how to use insulin, and it makes you look like you're all over the place. And somebody says, and then at some point, a doctor says, oh, well, you must be brittle. Nothing we can do. And I get that back then. No monitors, sometimes no meters, no CGMs for sure. I can see how they might think that, but that's how I think of this job. So I think of that girl who's now in her 30s, and her kid's probably 15 years old. And I think, and that kid's life might be better because I took 15 minutes to explain to her mom how like insulin works. You know,
that's amazing. Yeah.
So it's what I hope for everybody. I hope everybody gets something out of these conversations and goes forward and does this. I mean, there's part of me that thinks that doctors are just going to be pissed at me for talking like this. And there's part of me that hopes that they'll listen. And I don't know what's going to happen, but I'm just going to keep telling the story.
I think you should, because there's definitely a void. And I think just like I started out, I mean, this is how we learn. So, and you're contributing to that. So don't stop.
No, please. Don't worry. I love this job. I tell people all the time, I'm 52 years old. When I was 16, my grandmother forced my uncle to give me a job in his sheet metal shop. With the day I graduated from high school, when everybody else went out to a party after graduation, I went home and went to bed because I had to get up at 6 a.m. and go to my uncle's sheet metal shop and work there full time. I'd already been working there for 3 years part-time, and I honestly thought that was my whole life. And if you go find that kid and tell him one day you're going to make a living, you're going to enjoy what you're doing, and you're going to help people, that kid would not have believed you. So I have no plans on not doing this. This is maybe the greatest thing I've done outside of my family in my life. So, but I use that girl, like she sits in my heart when I do this podcast, and her story about her kid, and everybody else's that I've ever bumped into. I just get sad when I hear doctors say, there's nothing I could do. They didn't understand. And I'm like, I think everybody can understand. You just have to distill it enough that it works for everyone. I think that one of the biggest mistakes we make, I'll leave you with this. I think we teach to the least common denominator. And I think that's a bit of a mistake, right? I think you should just assume that everyone can absorb the information and wants it. You just have to find a way to say it so that the least and the greatest of us, as far as our ability to understand, so that we can all hear it. And I think that's what I've done here, really, is I've just found a common sense way to talk about diabetes in a plain spoken manner. And it doesn't matter if you've got a master's degree or you had to drop out of high school to have your baby. I think you can understand it. And that's all I think the doctors should be striving for, honestly. So anyway, that's
well
all
said. I agree.
Thank you. I appreciate it. I appreciate you doing this very much. So back to our original question at the beginning. No reason to make you anonymous in this, right?
No. I don't mind at all.
Good. Thank you. I really do appreciate it.
Yeah.
It was lovely of you to do this, especially on a Friday afternoon. And I have to tell you, if you want to come back sometime, I'd love to have you back.
Hey, thank you. I appreciate it. Yeah. And I honestly, if you ever want to do anything speaking wise, I'm involved in camp here in Michigan, both peds and adults. So it'd be awesome to have you as a talk.
I appreciate it. I would love to do that. I can never wrap my head around, well, you know what? Let's stop the recording and we'll talk about it privately. Do you mind?
Yeah,
okay.
By all means.
Thanks so much.
Yeah.
Type 1 diabetes can happen at any age. Are you at risk? Screen it like you mean it. Because if just one person in your family has type 1, you're up to 15 times more likely to get it too. So screen it like you mean it. One blood test can help you spot it early. And the more you know, the more you can do. So don't wait. Talk to your doctor about screening. Tap now or visit screenfortype1.com to get more info. And screen it like you mean it. Arden has been getting her diabetes supplies from US Med for 3 years. You can as well. usmed.com/juicebox or call 888-721-1514. My thanks to US Med for sponsoring this episode and for being longtime sponsors of the Juicebox podcast. There are links in the show notes and links at juiceboxpodcast.com to US Med and all of the sponsors. A huge thanks to Omnipod, not just my longest sponsor, but my first one. Omnipod.com/juicebox. If you love the podcast and you love tubeless insulin pumps, this link is for you. Omnipod.com/juicebox. If you enjoyed today's episode, go check out the rest of the Grand Round series. There's links. Let's see where you could find them. Well, here's the easiest place. Go into the private Facebook group, go up to the feature tab. There's links of all the series in there. You'll see every episode of the Grand Round series. You'll be able to go back into your podcast app and listen until your heart's content. If you're not already subscribed or following in your favorite audio app, please take the time now to do that. It really helps the show. And get those automatic downloads set up so you never miss an episode. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. The episode you just heard was professionally edited by Wrong Way Recording. WrongWayRecording.com.